I'm really, really pleased to be with everybody virtually. I only wish we could be together in person. And I want to just say how excited I am to be part of this series, and that I love the title of the series, right? Questions in Neonatal Ethics. During my tenure as chair of bioethics at the Cleveland Clinic, I often try to remind people that ethics is all about trying to be sure that we're asking the right questions. We don't always have the answers. In some sense, by definition, ethics is situations when the answers are hard, but at least we need to strive to ask the right questions. So we're going to talk today about some ethical issues in neonatal research, and I hope to have time for discussion at the end of the talk. So again, thanks everybody for being here. I have no financial interest to disclose that would be relevant to this talk. I do, however, out of an abundance of transparency, want to say that I have a consulting agreement with Insight as a member of their data sharing review committee, and another company called Vivus for consultation on issues of pediatric drug development and ethics. Those do not include medications for neonates. And Sabine, in my introduction, mentioned the book that I've done, Ethics and Research with Children, which is now in its second edition, and I do receive royalties, albeit minimal, I should say, for that book. So I know other lectures in the series have talked about clinical issues in neonatology, and I want to begin by distinguishing clinical ethics from research ethics. And the best way to do that, I think, is to distinguish research from practice. Dr. Robert Levine, in his really classic 1986 book on ethical issues in clinical research, takes this definition, which I think is from the regulatory language. It says research is a class of activities designed to develop or contribute to generalizable knowledge, whereas practice is activities designed solely to enhance the well-being of the individual patient or client. And I think you may even be able to see my cursor. I would highlight the word solely here in this definition. So Belmont Report, which is the foundation really of how we think ethically about human subjects research in this country, puts it this way in 1979. Research and practice may be carried on together when research is designed to evaluate the safety and efficacy of a therapy. This need not cause any confusion regarding whether or not the activity requires review. The general rule is that if there's any element of research in an activity, that activity should undergo review for the protection of human subjects. So the foundation of research ethics and regulation in the United States in Belmont says when in doubt, an IRB should review something that is being done, if it's research practice or some combination of those two. The World Medical Association research ethics code, also known as the Helsinki Code, at one point said, in the field of biomedical research, a fundamental distinction must be recognized between medical research, in which the aim is essentially diagnostic or therapeutic for a patient, and medical research, the essential object of which is purely scientific, without implying direct diagnostic or therapeutic value to the person subjected to the research. So we see sort of a different spin on how to think about the categorization of research and clinical care when we look at the World Medical Association definition. And often I think it's helpful to look globally to just sort of try to get a bigger picture of how things are viewed in different places. This rather simplistic diagram then says that the Belmont Report draws a line here. It says medical care is to your left, and everything to the right is considered research, whether it's non-therapeutic research or it's research with potential clinical benefits. And the regulatory language is prospect of direct benefit in the United States. So Helsinki draws the line here, which is kind of interesting, I think, right? It says when we're doing clinical research, that's one set of ethics. And when we're doing research that doesn't have any potential therapeutic benefit, that's a different set. Whereas in the United States, these are lumped together, clinical research and non-therapeutic research. And that's going to become important, I think, as we move on. It also in Helsinki says that in research on human subjects, considerations related to the well-being of the human subject should take precedence over the interests of science and society. And I think there's an important absence of this kind of statement in the United States regulations on human subjects research, and there's good and bad about the lack of clarity on this when it comes to research with adults in this country. But I think especially research in children and neonates, it would be helpful to think about the ethics of this statement. The Belmont Report has really three fundamental principles that it says is the foundation for human subject research in this country. And this kind of mirrors, the four principles from the Georgetown mantra, if you will, from Beecham and Childress's work, but it doesn't have non-maleficence. So the Belmont Report says that respect for persons, beneficence, and justice. And I put beneficence in red because I think it's probably the most important of the three principles for pediatric and neonatal research ethics. And we'll talk more about these principles also a bit later in the talk. When it comes to respect for persons, Belmont tells us that it incorporates at least two ethical convictions. The first one, not relevant to neonatal research. Individuals should be treated as autonomous agents. And the second one, actually quite relevant to neonatal research, that persons with diminished autonomy are entitled to protection. And obviously, neonates have greatly diminished autonomy. The principle of respect for persons, therefore, divides into two separate moral requirements that follow from these two ways of thinking. One needs to acknowledge autonomy for those who have it and protect those with diminished autonomy. And it goes on to say not every human being is capable of self-determination. It requires maturing during an individual's life. Sometimes individuals lose capacity. In your case with neonatal research, it's individuals who have never had capacity yet are certainly worthy of respect for persons. This may require protecting them as they mature or while they are incapacitated. Some persons are in need of extensive protection, even to the point of excluding them from activities that may harm them. Other persons require little protection beyond just making sure they undertake activities freely and with awareness of adverse consequences. And there's a sliding scale, a sort of titration that Belmont calls for that says the extent of protection afforded should depend on the risk of harm and the likelihood of benefit. And it should be periodically reevaluated. Again, probably not likely in the first year of life that an infant is going to develop any meaningful autonomy. But this idea overall for pediatric ethics becomes important when we talk about assent, which I'll touch on in a little bit. So the history, I think, is really important and interesting here, too. When I was sort of coming up through the ranks, doing my training in ethics, we talked purely about human subjects research. We never talked about participants, and it was very much a thing where subjects need protection because there was this legacy of abuse and exploitation. There was Tuskegee. There was the Nazi experiments. Willowbrook is a really interesting pediatric example, which there's actually a mixed story about. The traditional Willowbrook story is that it was abusive and exploitative, but there are defenders of what happened at Willowbrook too. And for those of you who want a deeper dive, I'd encourage you to read both sides of that story. But in the 90s, late 80s, early 90s, we started to talk about participants. Dr. Fauci, who's been in the news a lot the past couple of years, was sort of a central player in this, as HIV was a scourge through our country, and people were actively pushing to participate in research. Breast cancer advocacy groups, et cetera, et cetera. People started to see that access to research was something that might provide an inclusion benefit. And so the question became, do we talk about research subjects or research participants? In neonatal research, again, I think no one would argue that there's an active decision to participate by a baby. So I think subjects is actually better terminology for the cohort that you work with in neonatology. But to get a little more specific here about neonatal research, if we really want to be protective of babies because they have no autonomy, one might say we just shouldn't do neonatal research. And I think that is the wrong approach. I think there's an ethical imperative to conduct neonatal research. One of my colleagues and mentors, Dr. Alan Fleischman, has written eloquently about this. Dr. Fleischman is in New York and is a neonatologist and ethicist, and really, in some ways, the dean of neonatal ethics, I would say. And Alan, in one paper, talks about these examples where neonatal research was not conducted: the rapid infusion of bicarbonate to correct metabolic acidosis, the use of chloramphenicol for neonatal sepsis, not good for the bone marrow in some cases, oxygen for apnea prematurity, and high pressure ventilation for full-term babies who have severe hypoxia. Each of these represented harm to children that potentially could have been averted had research been done. So it was the incorporation of something that seemed like a good idea without the empirical study of it. I think many of us would say that is unethical. And how do we balance that out? And just to show a little example of the third bullet point, hopefully most of you know who this is. I think one of the great musical geniuses of the 20th century and 21st century. But in 1950, Stevie Wonder was exposed to too much oxygen without it having been studied. And when he was born as a premature infant in Detroit, I believe, and lost his vision for life. So this is a reminder that there is an ethical imperative to do research. And I love that photo. I'm just going to pause on it for a second so y'all can maybe imagine a great Stevie Wonder tune. I like Sir Duke. So what about neonates in research? We said before that they're subjects and they're not participants because they can't have affirmative agreement themselves. And therefore, we're left with parental permission rather than actual informed consent. Informed consent means only the patient himself or herself. And parental permission, as I'll show you in the next series of slides, is a bit different. But before we get there, I want to talk about risk and benefit. In informed consent, we talk about risk, benefit, and alternatives. And in research ethics, risk always means risk to the subject. But importantly, benefit can be benefit to the subject, but it also could be benefits to society, benefits to other babies, benefits to drug companies, benefits to investigators who are building their careers, collateral benefit potentially to the babies themselves. It's not considered direct medical benefit. So there's compensation potentially to babies and families, all kinds of things that could be benefit, but risk is risk to the subject. And if one thinks about the appropriate policy for pediatric research ethics, you could go down here and pick a very restrictive policy and say you can only do research on neonates when the risk is less than the benefit to the subject. Or you could do what is really the policy for adults, which is if you add together the benefit to the subject and benefit to society, if that balances against the risk, then it's permitted research. Or in the middle, one could say if it's other children with the same disease, or if it's other children as a class. But I want to point out here just the potential sort of continuum of pediatric research ethics policy. And you could even make it more restrictive to say there should be no pediatric, no neonatal research. I think that would be wrong. But it is a possible sort of policy approach. And That brings us to informed consent. And just to briefly remind everybody that the 4 elements for morally valid informed consent are disclosure, understanding, voluntariness, and competence. And voluntariness actually is the lack of coercion in a situation. Competence is more of a prerequisite than a criteria for morally valid consent. And I show this really because parental permission also, I think, requires these 4 elements. But in pediatrics, the idea of informed consent really is a combination of parental permission and assent. And in neonatal ethics, I think we can cross off the assent of the child. So really want to focus on parental permission and remind you that it is not the moral equivalent of informed consent because children are not the property of their parents. And also to put out there that parental permission and informed consent are different in the clinical context compared to the research context. And the way that they're different is that consent is more stringent in the research context. It needs to be documented more clearly. IRBs need to review the document and the explanation of risks, benefits, and alternatives, in my view, needs to be more exhaustive in the research context because there's an inherent conflict of interest. That is to say, in a fiduciary doctor-patient relationship where you're only practicing medicine, there's no reason theoretically for a patient to be concerned that you have anything other than his or her interests in mind. But if you're doing research and you're transparent about it, one needs to say, look, I'm wanting to help your baby. I hope things go well in the study, but we're doing this also to produce generalizable knowledge. And once one starts to go down that pathway, the informed consent or the parental permission requirement is more stringent, as I said. I've already mentioned that assent may be irrelevant, but is very central to pediatric research ethics when you get to any child above 7 in the 7 to 14, 15 range. Assent becomes very tricky. And I know many of you, look after children for whom the parents are teenagers and try to do your best at parental permission and discussion and communication with teenage parents. Many of them actually could be more in the assent range than the informed consent range. I know legally they may be able to provide parental permission as emancipated minors, but I think we could probably learn a lot about assent, and I think that's one of the areas in pediatric ethics generally that still requires a lot of work. The Belmont Report, which I mentioned before, has these 3 principles, but you may be saying, well, how do we operationalize that? How does Belmont move from theory to practice? One way to do that is getting informed consent, which is an expression of respect for persons, doing a good risk-benefit assessment, which I think is the basis of the principle of beneficence. And then when it comes to justice, there are lots of justice issues. As our society makes progress, we see justice issues, I think, more and more clearly all the time. But a classic one in research ethics is participant selection to make sure that, or subjects in the case of neonatal research, that we have a representative sample, that we're not overstudying or understudying any particular demographic. This is a simplification that doctors care for patients and researchers study subjects, but as I've tried to outline in the first part of the talk, for clinical research, it's a little more complex than that. I also want to just mention the centrality of consent as a foundation for research ethics in the late 40s after the Nazi atrocities and coming out of the Nuremberg trials of the Nazi doctors, an important code was promulgated. And the first point was that the voluntary consent of the human subject is absolutely essential. And then in small print, it said this means the person involved should have legal capacity to give consent. Well, that's a problem for you and for anyone wanting to do pediatric research on young children, right? Because this is a rhetorical question. Is it possible to adhere to Nuremberg and do pediatric research? And maybe the answer is no. But if the answer is no, then children as a group will suffer. We'll never make progress in childhood disease, be it RDS, be it NEC, be it childhood cancer, you name it. We need, I think, ethically to do pediatric research. So if the answer is yes, we can still adhere to Nuremberg, at least the spirit of Nuremberg, then we need to ask, how can we protect children in research risk? And what happened, I believe, after Nuremberg is that children were understandably overprotected. And as Harry Shirky wrote in the late 60s, and still unfortunately a bit relevant today, children became therapeutic orphans. By an odd and unfortunate twist of fate, infants and children are becoming therapeutic or pharmaceutical orphans. The drug laws of 1962 had their inception following a pediatric tragedy, but Shirky argued that that resulted in overprotection. So the pediatricians and neonatologists in your case didn't have the same level of data, evidence-based, to take care of our patients the way that adults did. Getting back to ways that we can still respect Nuremberg and do pediatric research, we can get parental permission. Number 2 is not relevant in neonatology, but number 3 is very important: societal protection and IRB approval. And I will tell you a tale of sort of a reversal of an IRB decision that may be familiar to many of you as we get toward the latter part of the talk. Again, from a policy perspective, I like to teach this as the 3 I's, the ways of protecting human subjects are by remembering the 3 I's. There's investigator integrity, IRB approval, and informed consent, or parental permission in the case of neonatology. And the next slide should show you my, at least, editorial comments on this. And this is having studied informed consent in the childhood cancer context for a long time, 15 years, 3 R01s, really trying to understand informed consent. It's not very effective at protecting human subjects. IRB approval is more effective, and I think investigator integrity is likely the most effective way of protecting human subjects. But the reverse trend is true with regard to enforceability. The signature of a parent on a parental permission informed consent document is quite enforceable. IRB approval is also enforceable, but one has a hard time, I think, measuring or enforcing investigator integrity. So all 3 of these are important ways of protecting subjects from research risk. And then that leads me to transition a little bit from the ethical principles to the regulatory framework. And you know, in the best of all worlds, regulations are derived from ethical principles. There are probably lots of other political factors, historical factors that come into play for regulations, but I think for you as an audience to have a really solid understanding of neonatal research ethics, it's important to understand the regulatory framework to some extent too. So this is in the HHS Code of Federal Regulations, 45 CFR 46. I will say that the FDA has a very analogous, it's not exactly the same code of regulations, but it's close enough that I don't think we need to go into both of them today. And these are overall elements of ethical considerations for human subjects research. These are not pediatric specific. They apply to adults, they apply to kids. It's important that the research design be sound without unnecessary risks. It doesn't say no risk. It doesn't even say low risk. It says no unnecessary risk. The risks have to be in proportion with a combination of benefits to the participant or subject and knowledge gain. You know, much like our ethos at Cleveland Clinic, safety is maximized. Safety has to always come first in research, in the design, just like it should in clinical care. Subject selection needs to be equitable. This is a tip of the hat to justice. Privacy and confidentiality has to be adequate, and informed consent has to be obtained. In the Code of Federal Regulations, though, there are also additional protections for children, which I'll share with you in a minute. But before we do that, I want to say something about sequence, and that is for the IRB review has to come before informed consent, parental permission, or assent. That's really the key here. An investigator is if she's designing a clinical trial, she needs to think that the risk-benefit ratio makes sense before she should even present it to an IRB. Then the IRB needs to review it and agree that the risk-benefit ratio is acceptable. And then it can get to parental permission or informed consent. But I personally don't think that parents or even adult patients should be put in a position where they're making a risk-benefit assessment where the protocol has not been reviewed by the IRB, and the IRB has a big responsibility, with expertise to say that it is a reasonable risk-benefit assessment. So here's the additional protections for children. They are primarily in Subpart D. Again, for the audience today, I think we'll touch just a little bit on Subpart B also. And this gets to the issue of IRB review. What categories of research with children are IRBs permitted to approve? It doesn't mean they have to approve them, but they're permitted, and these additional protections apply. And these are the 4 categories, and I'll spend a bit of time just sort of unpacking them for you. The first category is minimal risk. This is called the 404 category in the regulatory nomenclature. The 404s are usually said to be risk levels that are consistent with everyday life for a child. That's the sort of threshold that IRB should be thinking about. So is a venipuncture in a neonate minimal risk or greater than minimal risk? If a baby is at home in the nursery that their parents have just put together after the baby's born, are they likely to have a venipuncture done? No, but could something happen to them that's the same risk level as a venipuncture? Yes, and if that's the case, then the research, if it's just involving a venipuncture, would be approvable by an IRB. The controversy around minimal risk as a definition in pediatric research ethics is that we all know that there is heterogeneity around conditions of childhood. Children that are living in neighborhoods that are plagued by gun violence are at a different day-to-day risk level than children that are living in the suburbs that are usually overall safer places for children. Sometimes parents allow their children to go bungee jumping or skiing or snowboarding without a helmet. Should that be the definition of minimal risk, or should it be a more conservative, small c conservative definition that is sort of more an idealized protective state for children? So there is some debate about what is and is not minimal risk. The second category, which is also known as the 405 category, involves greater than minimal risk. And there's no ceiling here on the level of risk. It could be very, very high risk, but it has to present the prospect of direct benefit to the individual subject. And most pediatric cancer research, which is sort of the world that I live in and know best, is, I think, approved under this category. And I imagine a lot of your clinical trials are also in this category, but we'll talk about one example soon. But it's not just that the risk has to be outweighed by the prospect of direct benefit or the PODB. it has to be that the risk-benefit ratio is less than or equal to the alternatives. So it does sort of touch on what happens in clinical care as well. And if there's a clinical care option available where the risk-benefit ratio is better for the child, the IRB should not be approving it under the 405 category. So that's 405. The third category, also known as the 406, is greater than minimal risk, no prospect of benefit to the subject, but it's likely to yield generalizable knowledge about the subject's disorder or condition. And there is a ceiling of risk here. It has to be what's known as a minor increase over minimal risk. So the regulations don't allow us to expose children to crazy levels of risk if there's no benefit to them, but it does allow a minor increase over minimal risk. And again, that's for IRBs to debate. And I'm a big proponent of the central IRB movement because it does allow, I think, more consistency in agreeing to what the minor increase might look like, as opposed to a multi-site study with many IRBs that could view this definition differently. In addition to this ceiling of minor increase over minimal risk, the experiences have to be commensurate with actual or expected situations, and the information gained has to be of vital importance, and there has to be assent or parental permission. And I should go back here to these two categories require only one parent to provide permission. The third, and what I'll show you in a minute, the fourth category require both parents to provide permission if they're available. So the fourth category is perhaps the most interesting. Research not otherwise approvable, which presents an opportunity to understand, prevent, or alleviate a serious problem affecting the health and welfare of children. If the Secretary of Health and Human Services, after consulting with a panel of experts and allowing for public review, finds that it's compatible with sound ethical principles and there are provisions for assent and permission. This is a category that is the kind of thing where an IRB makes a referral to the federal government, and the IRB says, we think this is important research, but we can't approve it under the first three categories. Can you, Madam or Mr. Secretary, make this approval? Doesn't happen very often, but is, I think, super interesting when it does happen. Okay. So that takes us through Subpart D. I'd be remiss if I didn't mention at least that Subpart B is called Additional Protections for Pregnant Women, Human Fetuses, and Neonates Involved in Research. And it requires that research hold out the prospect of enhancing the probability of survival to the point of viability. That's, I suppose, for the fetal component of it. Developing important biological knowledge that cannot be obtained by other means. So either one of these, and no added risk to the neonate resulting from the research. So it's my understanding that most of the time IRBs use Subpart D to think about neonatal research and not Subpart B. I think the emphasis in Subpart B really is on pregnant women and human fetuses, but because neonates is in the title of Subpart B, I thought it would be important to put that there. Okay, we're gonna spend the last part of the talk about randomized clinical trials. And I'll start by saying that that the study design really matters for the ethics. If it's a phase 1, phase 2, phase 3 study, many phase 3 studies are randomized, some phase 2 are. And randomization is a difficult concept for patients, parents, or subjects or participants to understand. This idea of the therapeutic misconception is ubiquitous. I don't have time to go deeply into TM or therapeutic misconception, but I'd encourage you to read about it. It essentially says that when you are wearing a white coat and you approach someone to be in a medical study, they often think that you're talking about treatment or a diagnostic procedure that there's confusion that about whether you're doing research. You have the idea of informed consent gets blurred between the clinical goals and the research goals, and that's TM in a nutshell. And in our own work, in a paper we published 15 years ago or more now in JAMA, we studied parental understanding of randomized trials after children are diagnosed with leukemia, and 50% of parents did not understand randomization. In our interviews with parents, we had audio tape of the consent discussion that went on, and in 85% of the cases, we had on tape the doctor trying to explain randomization to parents, yet only 50% understood it. And all these parents got a consent document that tried to explain it. So randomization is a tough concept, but it's an important study design, obviously, for us to gather evidence. And central to understanding the ethics of randomization is the notion of equipoise. And it means on an individual level that the investigator has no treatment preference for a particular arm. You have to be totally neutral, and if you think that one treatment in a study is better than the other treatment, it would be unethical for you to participate in that study. The late great Benjamin Friedman talked about clinical equipoise. He said the individual level was sort of too high of a threshold. And he said within the expert medical community, there has to be genuine uncertainty, but a study could go forward if clinical equipoise was met. Regardless, disturbance in equipoise makes randomization unethical. And equipoise in a classical sense is a little bit, I want to distinguish, I guess, randomization really and equipoise in the classical sense versus CER, study design, which is comparative effectiveness research. So a classical example might be a study in childhood cancer, let's say for neuroblastoma, where the last study showed that a 3-drug regimen worked the best. And working the best in this case means highest cure rate combined with the lowest amount of toxicity. But there's a new drug for neuroblastoma, and if the study design is to add that new drug to the 3 proven drugs in a randomized fashion. So half of the patients will get the 3 drugs, half the patients will get the 3 drugs plus the new drug. And if the new drug is experimental, it would be permissible to do this study. The hypothesis might be that the second arm with the new drug is going to have a higher cure rate, but there's a risk of more toxicity. And unless you do the study, you're not going to know the answer to that question. So that could be an application of equipoise. Comparative effectiveness research also should require equipoise, but it's kind of a different thing because it's the study of 2 things that are already in practice, that there is practice variation. We know from Dartmouth Atlas and other important work that medical practice varies by geography, by other things, and CER research attempts to answer a question about things that are within things that are already being done. So there was an important study in neonatology I suspect many of you are familiar with, perhaps even more familiar than me, and I'd love to get your thoughts and input on this during the discussion. It was called the Subpart study. 1,300 babies who were between 24 and 27 weeks gestational age were randomized. And in clinical practice at the time, as I understand it, there was uncertainty. Some people hypothesized that a target oxygen range of 85 to 89% was best using pulse oximetry, others 91 to 95%. And the study looked at what was called a composite outcome of retinopathy of prematurity or death. The or is important here. And the hypothesis was that the lower target range would reduce the incidence of this composite outcome. The result, published in 2010 in the New England Journal, is that there was no difference, but there was less retinopathy in the low target group. Perhaps that would have been hypothesized, from the Stevie Wonder experience. But importantly, maybe even more important, right, there was less death before discharge in the high target group. So the predetermined outcomes was this composite of retinopathy and death. But I think the higher death in the low oxygen group got people's attention, as it probably should have. But then there was sort of all hell broke loose, if you will. The Office of Human Research Protection, which is part of the federal government, criticized the investigators after this was published and criticized the IRB for inadequate consent. And this reminds me to mention that consent isn't just a document, it's a process. And OHRP's criticism was necessarily a criticism of the document because that's all they had really to look at. There were no audio tapes or videotapes of the consent process. Really, I think the controversy was about how much incremental risk babies were exposed to, and defenders of this study said there was no incremental risk because all of this was within this umbrella of comparative effectiveness research. The other interesting thing, I believe, is that the study was approved as minimal risk because the assertion was that comparative effectiveness research is all minimal risk because it's no more incremental risk. But it maybe should have been a 405 that there was prospective benefit. At least I think OHRP suggested that. So this was kind of an after the fact ding by the federal government. And a question was, does randomization itself increase in the risk in the context of CER research? They were both considered standard at the time of the study. One group of ethicists strongly criticized the study in a letter to the New England Journal. Francis Collins and Kathy Hudson, who were leadership of NIH at the time, defended it in 2013 in the New England Journal. And another group of ethicists, including me, for full disclosure, wrote a letter in support of the Subpart study. So I think that's a really important paradigm example of neonatal research ethics to bring to your attention if you weren't aware of it, and maybe we can talk about it. A few more slides and then I look forward to the discussion. I think that well-intended regulatory protections can paradoxically sometimes prevent the ethical participation of infants and children in clinical research, leading to things like the therapeutic orphan problem. And I think in the end, we really need a synergistic approach where we do have regulations. I would never say regulations are unimportant, but also education to try to enhance investigator integrity and help people be thoughtful about the protection of human subjects. And I hope that what we're doing today in some small part is contributing to the education piece of it. All research ethics is a balance. The best interests of the child subject are balanced against science to benefit others. And I think we do need to lean a little more heavy on the best interests of the child subject as opposed to adult ethics, where it is adult research ethics fair enough to do more science to benefit others, especially if you have good informed consent. As I said before, beneficence, I think, is the North Star. It should be guiding neonatology research. I'm going to get a little normative with you here. I think risk-benefit assessment is more important than parental permission and consent. Not to say parental permission is unimportant, but it doesn't justify going ahead to do studies if the risk-benefit ratio isn't good. These are both ethically important things, protecting neonates from research risk and the imperative to improve the treatment of sick babies. I mentioned the regulatory fervor sometimes that I think can backfire. I'll remind you that children are both vulnerable subjects who need protection and a neglected class that needs better access to the benefits of research. And then to remind you that good ethics starts with good science, but good science is not inherently ethical. And for that reason, some, I think, tantalizing research that may turn out to be great for society needs to be rejected on ethical grounds. And in my last slide, I'd just like to quote Hans Jonas from 1969. This is more than 50 years ago, but I think it still holds true. Jonas says, "Let us not forget that progress is an optional goal, not an unconditional commitment, and that its tempo in particular, compulsive as it may become, has nothing sacred about it. Let us also remember that a slower progress in the conquest of disease would not threaten society, grievous as it is to those who have to deplore that their particular disease has not yet been conquered. But society would indeed be threatened by the erosion of moral values whose loss, possibly caused by too ruthless a pursuit of scientific progress, would make its most dazzling triumphs not worth having." And that is my last slide. I want to thank you for your attention. My email address is here if people want to continue the conversation afterwards.